In 5, 4, 3, 2, 1. We are live.
Yeah. So, a very good evening to all of you again. On behalf of Young Surgeons Forum, I welcome you all for this further exciting episode. As you all know, this is a brainchild from Dr. Wasudeo Gadegone and OrthoTV, Dr. Ashok, Shyam and Dr. Bijlani. This is an academic platform to give chance for the young orthopedic surgeons to showcase their work on this global platform. I am Dr. Manoj Pahukar. I will be moderating this today's session. We are very fortunate to have Vidarbha Orthopaedic Society from Nagpur as a guest society for this today's episode. As you already know, we have conducted around 21 episodes before, and this will be the 22nd episode. VOS Nagpur is also my home society. Here I worked in various positions for this society. This society has produced many national and international stalwarts all across. And we are lucky to have Dr. Makarand, Dhopavkar, who is current VOS president, as a convener for this today's session, and Dr. Neha Godghate, who is a VOS secretary, who will be coordinating this today's session, and Dr. Nitin, Kimmatkar, one of the eminent faculty with the panelist and VOS member as well as MOA executive for this today's session. So I welcome you all three for this session. And I also welcome all the 6 speakers from across Vidarbha who will be presenting and showcasing their difficult case scenario work over here. And we will be serving various dishes from different subspecialties. I think we'll be having a case from all individual specialty so as to give a good compendium of various cases, which will be the theme for this today's Young Surgeon Forum episode. So without much further ado, we'll ask Dr. Wasudeo Gadegone, sir, MOA President, to give a welcome address.
On behalf of Maharashtra Orthopedic Association, Dr. Wasudeo Gadegone, I am welcome you all, the speakers of Vidarbha Orthopaedic Society from all corners from Nagpur, Amravati, Akola. And I also congratulate Dr. Manoj Pahukar and Nitin Kimmatkar, Neha Godghate and Makarand Dhopavkar for initiating this Vidarbha Orthopaedic Society clinical cases presentation for Maharashtra Orthopedic Association educational activity. I thank all viewers of Maharashtra Orthopedic Association members and also the viewers of OrthoTV. So best luck, and Manoj Pahukar, over to you to continue the further proceedings.
Yeah, so now I invite Dr. Makarand Dhopavkar, sir, who is a VOS president, who is also convener for this today's session, to speak a few words about this today's episode.
Thank you, Manoj. Gadegone, sir, on behalf of Vidarbha Orthopaedic Society, I welcome all of you to this Zoom meeting. This is Young Surgeons Forum, which is being hosted by Vidarbha Orthopaedic Society. In fact, we are very grateful to you, Dr. Gadegone, who is presently the president of Maharashtra Orthopaedic Association, for giving the young surgeons of Vidarbha this opportunity to present their clinical work. We have very prominent faculty from Vidarbha presenting their cases today evening, and without wasting any further time, I hand over the proceedings to Manoj to start with the clinical cases.
Yeah. Thank you, Makarand, sir. So now we'll start with, we are having 6 cases today, 15 minutes for each case, around 8-minute presentation and 5 to 6 minute discussion. It could be interactive as well. And we'll start with the first case by Dr. Girish Motwani. And may I ask Neeraj to please introduce himself. Till that time, he can start sharing his screen.
Thank you, sir. Our first presenter is Dr. Girish Motwani. He is a consultant foot and ankle orthopedic surgeon. He is the director of Soyog Hospital at Nagpur. He has done his MBBS from Nagpur and his MS with a gold medal from Baroda. He is a faculty in more than 30 national and state orthopedic conferences and has research publications, more than 10 research publications. Welcome, Girish.
Thank you, Neeraj sir, for the kind introduction, and thank you, Makarand sir, Manoj sir, Gadegone sir, Nitin sir, for the excellent opportunity on presenting in our own town, in our own society. Am I audible and visible, sir?
Yeah, please.
So my case is a very simple ankle fracture management, but how the management is different when there is some comorbidity. And here I will discuss a diabetic condition and an ankle fracture, how it is different from the normal fracture. So 50-year-old, he's a diabetic smoker, alcoholic. He had a history of falling from the stairs, and he injured his right ankle. And immediately after the injury, there was some swelling, and he has been treated in other hospital with the below knee cast for next 3 weeks, saying that there is a small minor fracture in the ankle. Sorry, I don't have that X-ray, but this is what the patient has told to us. And the immediate post-op X-ray, as I said, it is not available. But this was the condition when the patient presented to us after 5 weeks. 5 weeks of the injury. So we don't have the clinical and the radiological detail on day 1, but this is what they have presented at 5 weeks. It was a swollen, warm, erythematous ankle, as you can see. By just having a look on the skin on the forefoot, you may appreciate that he has just came out from the plaster. But overall, as in general, it looks like a quite of infection or a vascular problem. But the thing was, there was a very little pain or almost no pain, and patient came walking to the OPD. He has been treated by looking at this condition. He has been treated for the IV antibiotics, and because it was a very strong suspicion of the infection, so meropenem was also given. So this is how the patient was walking at 5 weeks just after removal of the plaster, and this were the X-ray which were done in our setups at 5 weeks. So to make the session more interactive, I would like to ask Dr. Nitin sir. Sir, how should we proceed, sir? This is what the clinical condition of the patient is there, and these are the present X-ray at 5 weeks. What do you think, sir? How should we proceed?
How much is the pain in this patient?
Pain is almost very negligible, sir. They said at the time of injury there was some pain, but at 5 weeks, patient is walking comfortably with this kind of deformity, and they came to us with no stick and this X-ray.
This significant deformity and this fracture, patient should have significant amount of pain. If he is not having pain, then we should think of Charcot and investigate on that lines that whether he is having diabetes or something else.
He's a diabetic, sir. He's a diabetic.
So the diagnosis is then certain that he has a Charcot joint, Charcot ankle joint.
Okay. Manoj sir, in your experience, how common is to see the Charcot arthropathy at 5 weeks of the injury? Because it's just 5. Charcot takes, we have learned that Charcot, it takes a little longer time, 3-4 months kind of thing. How the Charcot, can you suspect the Charcot as a first, or you think something else? Sir, you are mute.
I think the title which I already demonstrated is like the patient with the diabetes. So we need to consider all these possibilities like the neuropathy, the vasculopathy, the severe osteoporosis, the chances of soft tissue having this infection. So all these 3 or 4 additional problems which this patient could have simultaneously should be evaluated. As far as your question is concerned, certainly Charcot's arthropathy to manifest and to see within 5 weeks is certainly not that common. It is usually a very long-standing presentations. Patient may not be able to sometimes sense those limbs because of they don't have any sensory or motor problems as such. But sometimes with injury, the previous existing this Charcot neuropathy could manifest, and then simultaneously you could see such situation.
Okay, great, sir. Sir, the same thing was kept in our mind that this could be Charcot, but I was a little confused that how the Charcot can manifest so early. So it's better. We should, anyway, it requires fixation. We all are agree that it requires fixation. So patient has been evaluated for the surgery. CBC was normal. There was no parameter suggestive of infection. Peripheral Doppler, as Manoj sir has said, vasculopathy should be ruled out. Peripheral Doppler was normal. HbA1c was an amazing finding. It was 11.5 and random blood sugar was 345. And it is an acute fracture, 5 weeks old. CT was done. Sorry, I don't have the films, but the report was saying that there is some fracture in talus, some displaced fracture of medial malleus, displaced fracture of comminuted fracture of the calcaneum, and these are all with the lateral subluxation of the fragments. And this is what, like whatever we are seeing on the X-ray, nothing new. So they have given us the idea about what we have seen in the plain X-ray. So these are the 4 options. I would ask like the opinion of Dr. Dhopavkar sir. He's our senior trauma surgeon. Sir, these are like, I don't think that we should think of 4th or 5th option. Either we can splint them, control the diabetes when we get a good control of the HbA1c, and then we can plan for open reduction interfixation. Or the next option is the joint spanning external fixator, control the sugar, and then do the open reduction, like 2-stage protocol. Or we can go for the control for the blood sugar, insulin, take it to the insulin and do the ORIF in one setting. Or it is not reconstructible and we should fuse them with calcaneum and the talus after the blood sugar is controlled with the insulin. So what do you think, sir? How should I proceed?
See, I think it is already a 5 weeks old injury.
Yes.
Unfortunately, I am not able to see your PPT in full size. It is very small magnified image that I am able to see. But
Okay.
It is a 5 weeks old injury. And I don't think waiting any further is going to contribute to the improvement in patient's condition. So I think whatever HbA1c is going to take at least 2 to 3 months time to come to normal. So HbA1c reflects the glycemic control.
Yeah, yes.
I am not able to see the full screen. The slides are very magnified in one corner of my screen. Anyway, what can
all others able to see? I think there's some problem.
Okay.
Sir, Manoj sir, can you see the moving slides?
Yeah.
I can see the slides moving, but I can see a very small,
sorry, sir.
3 to 4 centimeter small in one corner of my screen. I'll just get it corrected.
Yes.
So I think there is no point in waiting further. There is no point in allowing or waiting till the HbA1c comes to normal. So if my protocol is, if with insulin you can maintain the blood sugar levels around 200, I think they are fair enough. If there are no local signs of infection clinically, and if, as you said, the Doppler is normal, so vascular rate is good, I think 5 weeks is the, I don't think there is any point in waiting any further if there are no local signs of infection, and you should just go ahead with whatever you have planned. I'm sorry, I'm not able to see the X-ray clearly. I'll get.
Okay, sorry, sir. Sorry. So, should we plan for the open reduction interfixation immediately and control the sugar simultaneously with the insulin?
You should start the patient on insulin, and once the sugar levels come around 200, I think that is the optimum time to get the patient in the OT.
Right, sir. Right. Thank you, sir. So we followed the sir advice, what the sir have said, and the patient was planned. Once the sugar was controlled in 2-3 days with the insulin, the patient was opened for the open reduction interfixation, and immediately after opening the medial side, this is what we got inside the operation theater. So there was no cartilage, absolutely no cartilage which was found reconstructible. There was huge amount of the bone loss. Everything was like fluffy. Whole of the bone was coming like a soft cotton, and there was hardly the pieces of the loose body inside the ankle joint which were reconstructible. So this is what intraoperatively we felt that we should go with the option D, but we have not planned for the fusion because nobody can plan. I think we all will go for the open reduction interfixation as far as it looks reconstructible. But this is what I want to emphasize here, that things which are at the molecular level cannot be seen on the CT scan. Somehow intraoperatively, because we have all plates, we were not prepared for the fusion. So somehow we get some bone graft, and from the iliac crest, from some local graft, we took out all the cartilage, all the fluffy bones, huge defects, and finally the extensile, anteromedial, and the transfibular approaches. And this is how the plating was done after fibulectomy. And I mean, using the fibula as a local stud and 2 plates, because we didn't have the nail availability, because we were not prepared for the fusion. And this is how, with the help of local available implants in the operation theater, the fusion was done successfully with no deformity, with some locking, some cortical screw. Somehow it is managed, and this is how the closure was done. Fortunately, we got epithelialization of the ankle suture, I mean the suture margins, and all, there was no vasculopathy. So fortunately, 8 weeks down the line, everything was healed. It was a delayed healing, and this is what at 10 weeks we found that the things are consolidating. There were really a good news that the foot is salvaged, and the uniting callus at the 10 weeks they gave us the another confidence that this is doing good. But this is how he presented 11 months down the line. Again, he had a small fall, and this is how he presented. We all are aware that this is the peri-implant stress riser effect, and this is not an ideal fusion technique, but you know my problems, what we have done in the first surgery. But how to manage this situation? Diabetic, osteoporotic, already diagnosed Charcot with the peri-implant fracture. I don't want to waste the time because there is a limitation. So to avoid the long incision, again, just we have revised the one plate. We have removed the plate from the anteromedial side, and the longer plate was applied. At that time, the TTC nail was also not available, and fortunately, 6 weeks down the line, things were healed, and there was a lot of uniting callus, and this is how the patient was, the soft tissue healing was done, and single heel rise standing he has started 18 months after the surgery. So this is how for the small ankle fracture, the things goes wrong, and finally 18 months down the line of the second surgery, he started walking. The things which I learned in this case, which I want to share with all you, that diabetic ankle fractures, they behave differently in presence of neuropathy. The Charcot process may start with the chip fracture also, because it's a weight-bearing joint. So don't underestimate that it is a minor fracture. It will heal up. No, there could be the aggressive bone destruction if it is associated with Charcot arthropathy, neuropathy. Many of the conditions, they have been misdiagnosed as a cellulitis of the infection, but it is actually Charcot. Always ask for the history of neuropathy. Examine the neuropathy. Is there any sensory loss? Do the monofilament test. Is there any loss in the ankle and the foot and not in the distal leg? If it is doubt, go for the electrophysiological study. Even a minor fracture can be catastrophic. Beware of the simple chip fractures. Always rule out the displaced fracture in the CT scan. But in a diabetic patient and the ankle injury, you need more investigations, CT, Doppler, longer period of immobilization, almost double the period of non-weight bearing as compared to the normal ankle injuries. More fixation, stronger fixation, intramedullary implants should be available, may require the fusion most of the time. Thank you.
Wonderful presentation, Girish.
Yeah, Girish, I think it was a wonderful case, and the results were fantastic, amazing. There are a few things which I'd like to ask is like, once you had diagnosed it is a painless ankle fracture in the first stage itself, so you're suspecting some kind of neuropathy. So where you're not anticipating there will be chances of more fixation failures if you go for such fractures in the beginning. And the second part is like the kind of fusion technique with dual plates which are used in the ankle is certainly, I think, is not quite will have its own problem because of the wound complications which are very high at that side. Usually we try to put the more number of screws crossing. That is another method of doing it. The TTC was not available. These two questions, how do you manage that?
Yeah. So the my first mistake was I missed the consequences of Charcot arthropathy at 5 weeks. I thought that open adduction interfixation is possible, but the fixation should be very strong. If I do the routine fixation for the medial malleus plating, I just do the distal tibial plating. But here, if I am doing this case, I have prepared for the protibial syndesmotic screw fixation. So this is the only indication in the ankle where if there is no syndesmotic injury, still you have to put 6 or 7 transsyndesmotic screws. So I was prepared for that. But my biggest mistake was we should be prepared for the fusion on tip. So because of the availability of the implants made for the ORIF only, there was no arrangements done for the ankle fusion. So this was my second mistake. So this is how, even if it is neuropathy, you can go for the open adduction interfixation, but you may get a drastic dissolution of the bone at 5 to 6 weeks if the neuropathy is bad and the patient is walking. Because every step, every walk creates a lot of catastrophe formation, inflammatory reaction, and it leads to local osteopenia and further loss of the bone, and it becomes non-reconstructible. But it was unexpected at 5 weeks. But this is what the mistake I want to discuss with everyone.
That was, I think, fantastic case with too many take-home messages. Any further questions?
Girish,
Girish, how do you judge that the fracture is united?
Sir, there was the bridging callus was available.
The callus maybe because of that you have put a bone graft and that is reorganizing, which is looking like a callus formation. Because in a compression plate which you did for a fresh stress fracture, and if there is a callus formation, that means you have not used the principle of locking plate. And,
correct, sir. Correct. Because this is not a plate meant for the fusion. But you cannot follow the ideal principle of the locking plate here, because this is my second mistake, that I thought it is possible with the ORIF only, and nothing was prepared for the fusion. That is what I want to say.
What are the chances in future that it may again go for a loosening of the screws and recurrence of the symptoms?
Sir, you have to control the bone mineral density. You have to control the sugar, control the neuropathy, and improve the bone mineral density. Make them non-weight bearing for more period of time as compared to the non-neuropathic fracture. This is how we can manage this patient. But the best way in 2020, I would say, after the availability of the intramedullary nail with 5-degree valgus, now I think these cases are very easy to manage. This was a case which was done in 2015 when there was a deficiency of the implants.
Do you think that the below knee support like a brace is required for this type of injury after fixation?
Absolutely, sir. Because you need a double period of immobilization. That's what I said, that you need a double period of immobilization, and everything should be double. Longer duration of immobilization, 2 times. If we immobilize at 3 months, we should mobilize at 6 months for the neuropathic. Brace application double the time. So if we give the brace for 2 months, we should give the brace here for 4 months.
Chalo, fantastic. Next case.
Yeah. Thank you, Girish.
Thank you, sir.
Yeah. Now I invite the second speaker for this today's episode, Dr. Alok Umre, who will be presenting a case of a joint replacement. His topic is a difficult scenario of managing polio limb with THR. May I ask Nina to briefly introduce Dr. Alok?
Dr. Alok Umre sir is a trauma and joint replacement surgeon. In fact, he's one of the leading trauma and joint replacement surgeons in Nagpur. He's the director of Arogyam Hospital. He did his MS from Nagpur and DNB. And I would like Alok sir to start his presentation. Thank you.
Good evening, sir. I thank Gadegone sir, Dr. Dhopavkar sir, and Manoj to allow me to have this presentation today. Thanks, Neeraj, for the introduction. And I'm just presenting a case wherein a young lady had a fall at home in Uttar Pradesh around 3 years back. She showed to us after her primary surgery, she had taken primary treatment in other state for the same. And when she came to us, it was the limb was in external rotation. She was bed bound. And to add to her woes, she is a known case of polio limb. And she was on chemotherapy for her breast cancer. So the only positive was she used to walk before all this fall happened. And these are the x-rays. These are the only x-rays I have which I could get from the previous trauma. So a polio limb with a neck femur fracture. I would like to have opinion of our senior faculties. Right? How would you like to manage this case?
Look, polio is affecting which part of the lower limb? Is it
Sir,
involving the hip? Hip also?
Hip, knee, as well as ankle.
Okay. So is it a flail hip?
Yes, sir. It's a flail hip.
Any flexion deformity? Now with the fracture, it could be because of long. It's a 3 years old fracture.
So no, this was a case which was came to us 3 years back.
Okay.
She had come to us 6 months back.
Okay.
I mean,
6 months after sustaining the fracture. Okay. Okay. So
her age is 47, 48 years old.
Right. Now, the biggest challenge in a patient who has got a polio is, apart from narrow medullary canal and coxa valga and other things, is the muscle imbalance around the hip. So the incidence of dislocation in a normal hip with the normal muscle power around the hip is about 2 to 4% with posterior approach. So in a limb which is already there is a muscle imbalance, I think the incidence of dislocation would be quite high. So maybe you may have to go for some kind of a constrained implant or something like that.
Her age was only 47.
47, yeah. So
Alok.
Sir, yes, sir.
Why did you not try for some
osteotomy? Yeah.
Because you need a better quality X-ray, traction view, whether the head is viable or not. If the head is viable, there is a still chance, because patient is walking on a polio limb with a flail, knee hand gait or something like that. Probably if you restore the hip joint, because she was going to weight bear fully, maybe with assisted, and if you preserve the femoral head, probably it would have been better for the
very true,
patient.
sir. Very true, sir. So I would just like to share that this was operated in Uttar Pradesh by the primary surgeon, and as you rightly pointed out, this should have been fixed. The initial attempt should have been to fix the fracture, but unfortunately they didn't follow the basics, and they did this. They had taken her for hemiarthroplasty, and now this was the state in which she presented to us after 6 months of the index surgery.
So everything is gone. There must be a removal of the implant because of the loosening or something like that.
They have done only girdle stone, sir.
Yes,
they have
sir.
done.
Yeah. So this was a girdle stone done there, and her only hope of walking is now over. So she was not walking with this particular limb now. She is bed bound, and limb is in external rotation. So how do we proceed from here now? So we can have opinions of all, Kimmatkar sir, Sanjay, everyone.
What is the power in the limb? Alok,
sir, yeah, I am coming to it, sir. She has very less power, the grade 2, grade 3 power in her hip. Only her ankle, foot movements are present. Knee extension is there, grade 4 power is there. Knee flexion is there. Hip abduction is absent with this particular.
She had a considerable power. If you restore the femoral head, probably she could walk. That is should be your aim.
Very true, sir.
But Alok, you said hip abductor power is grade 2.
Yes, sir, very hip abductor.
Very
Because
big.
that was the history. Because with this particular limb, she couldn't move her limb.
Okay.
Alok,
Yes, sir.
what are the physical requirements of the patient? Like, is she
Yeah.
able to walk with this? She is not able to walk.
She is not able to walk with this since last 6 months.
Okay, so she is bedridden, you mean?
Yeah, she was bedridden then.
And she is ready to accept the complications associated with further treatments in the because just a pencil thin bone. It's a very
Yeah.
small bone. Diffuse osteopenia is there. We need to explain them risk of iatrogenic fracture, protrusio, implant
dislocated.
loosening.
Very true, sir. She just wanted to be her on her own limb. She was a spinster, and she didn't wanted to rely on anyone else for her all her activities.
But do you agree? Like, we need to inform her that at times it's not necessary for every one of them to improve after
Hello?
surgery. Like, someone.
Very true, sir.
Hello?
Yes. Yes, sir.
Hello.
Sir, this was done, and her detailed consent was taken that whatever we would do would be on a sort of a, not exactly trial, but would be to enhance her, make her walk again, but we may fail.
Alok.
Yes, sir. Yes,
Can I say something?
Yes,
I think with all her comorbid poliotic limb,
yes, sir.
flail hip, a dislocated already a girdle stone, I think I
Yes.
would have gone ahead with a pelvic supportive osteotomy if by any chance there was inability to walk because of. I think it requires a daredevil surgeon like you to decide or to take a decision of doing a hip replacement in this kind of a situation with a small narrow canal with a paralytic hip and weakness of hip abductors. But yes, you go ahead with what you did, please.
So next, these were the challenges which we had faced, and we did a CT scan, and if you can see the diameter was 4 mm. We made a bone model. We made a bone model out of it, and you can see the middle one. This is a normal femur on the left side, and the lower side you can see the diseased bone.
So this is
So
rapid
literature
prototyping model.
suggested- Yeah, the literature suggested that there were only 1 or 2 cases of this particular diameter being operated with a Zimmer stem. The only issue was they had good power there, and this particular stem, Zimmer stem of 4 mm, is not available in India. So now, as you rightly pointed out, sir, there was a pelvic support osteotomy in our mind, THR in our mind, or the other thing which I didn't prefer, send her back. So this was the X-rays, and then we thought of doing something different. We tried to put in a hip there. We increased the canal diameter to 6 to 7 mm. We used those flexible reamers. Zimmer has them good quality, which increases gradually. We just try to increase the diameter, and this was what we could achieve then. Plan was, this is a dual mobility striker uncemented cup, and since striker doesn't have so narrow stem, we went ahead with the S-Rome debut stem. The only thing is we rimmed to 7 mm and we thought of putting in a 6, but on table, I don't know why I put in a 7 mm stem. I thought since the diameter is 7, so I can go ahead with 7. So last few I had to use a bit hammer it inside it. So that was the thing which was there. We didn't get any other view. This was the only view we had. Abduction pillow was given. And this was a mix and match, debut and striker.
I think you are able to get a good hip joint orientation. I think I think you are able to get good length and stability on table.
Yeah, the length, the stability was quite good. And since it was a dual mobility, it was not dislocating. So I think we were that time on table, we were satisfied. And post reduction, we just tried to do her limb movements. It was okay. And we thought that we were in a better position. A couple of days went back, she was doing well. Physiotherapy, then we started doing it a bit more, day 3, day 4, day 5 exercises more aggressively, whatever she could sustain. But on day 5th, we had this big problem. We had a fracture. We had a periprosthetic fracture. And that was a disaster for us. So now my next question is, how do we move ahead from here now?
This is what I was saying, Alok.
So how do we proceed from here now?
Immediate post of lateral X-ray.
The lateral X-ray is in the middle one. Immediate lateral X-ray we didn't do.
No, Alok.
That was, yes, sir.
This was even before the staples were out, no?
Yes, sir. Fifth day.
Fifth day. Probably the cause could be
staple pins.
There has to be some splintering, maybe.
Because there is excessive bowing in femur in most of the poliotic limbs, apart from excessive anteversion of the neck, for which you use Esseron. But there is a bowing of the femur, which
definitely,
yeah.
And I did a mistake of hammering the last few, because that was the grid to make it more press fit, and I think that was where I erred on a very major wrongdoing was on my part. So now, how do we proceed from here?
So I think now this is a Weber 2 kind of periprosthetic, and certainly I think the proximally hip and this metaphyseal area looks all right. Only I think you need to manage this diaphyseal component.
Yeah. No, not only that.
It is extending up to the metaphysis. Manoj, if you can see the right corner X-ray.
That it is going up to the greater trochanter. You can see at the subtrochanteric level, it's a spiral fracture, and whole femur is rotated. And therefore, if you want to construct, we have to go from the greater trochanter towards the subtrochanteric region of the femur. Long plate with all cables and everything, and then it is possible to repair this fracture.
Sir, which particular plate can we think of using here, sir?
Long hook plate, if it is available.
Yes, I think it's a Zimmer has that the trochanteric plate hooks on.
That is very short. That is very short, Manoj.
No, I think it's a whole long length, complete to femur length. The plates are available.
Manoj, the thickness of that plate and the diameter and the length and the width of the plate will that match here?
Yeah, this will not be that situation over here.
Even a distal femoral plate of the opposite side can do.
But sir, the width of the bone, sir.
Yeah.
I think here
maybe a Philos plate, long Philos plate might do.
Yes.
The humerus kind of plates will be sufficient around here. Seeing the diameters were corresponding to the humerus now.
Not only plate, but it has to be augmented
circularized
with cables.
Yes,
cables.
Very true, sir. Very true. Very true. And this was a disaster that we faced. So, as you rightly pointed out, we can have these options of fixation by plates and cables, or any other option. So this is a distal tibia plate, locking plate, which bailed us out here. And as you can all see, we tried to reduce it, use cables, encerclage, screws, and prayer. and we could get a good reduction. Fortunately, this was a primary reduction, and
Yeah, it looks good. Yeah, I think apart from maybe a 1 or 2 metaphysical more screws towards GT, the rest of the things it is all right.
yeah, but
Very difficult.
very true. Very
Yeah.
true. That GT screws I could have put, but I was just, there was a fear factor in me.
Yeah, already this is more challenging. We are able to get good reduction because we are able to at least get the whole stem inside properly in the canal, get all reduced with all those diameters available, and even a good contoured plate matching that profile also you could match. You could do that.
So one question.
Yes, ma'am. Yes, Neha.
Yeah. So was the stem also revised to 6 mm or it was the same 7
7 mm stem was put in, and I regret that I should have put in a 6 mm stem, but I don't know. I mean, that was a regret after the fracture. Till then,
So
I didn't
did
have
you
it.
revise the stem after the fracture?
No. Stem was kept at 7 mm only. I didn't revise the stem.
Okay.
I kept it at the same length.
Yeah.
I didn't do anything for the hip. I just went ahead and fixed the periprosthetic fracture, and these were post-op X-rays. And this is at 7 months. And this now, after this surgery, the patient never turned up a follow-up, but I was very keen to get the follow-up done. So I was the one who was used to like phone and get the कि आप X-ray कराओ मेरे को देखना है करके and all those, so this was way she came once when we had this particular follow-up, and the next follow-up I'll just show. This is follow-up at 21 months. The patient, this is the only way she was walking before the fall. This is her gait before the fall. You can see the braces. Except walker, she was on crutches. The walker is what we suggested. This is the video sent by her brother from Uttar Pradesh. And this is a 3-year follow-up. And she was dealing with the malignancy. She was on chemotherapy for her breast cancer.
Alok, I do agree with your heroic surgery. Actually, the wonderful result. But in a polio limb, when there is no hip dysfunction is already there, and there is a while walking, there is a thrusting movement of the hip joint, erosion, loosening, and these are all the things can happen in future, even
Yes,
a dislocation also. So
Yes,
I
sir.
think it is a very good surgery you have done it. The solution you have brought out, it is also very good. It is one of a wonderful surgery. But if you ask me, I would have done a pelvic support osteotomy
Yeah.
and
Agree, sir.
lengthening at the supracondylar level.
Very true, sir. I mean, that was an option that time also, and I agree that that was a better option. But I thought that giving her next to original hip was what in my mind.
So one question.
Yes,
Alok,
sir.
one question.
Yeah.
On the acetabular side, were you able to use the TAL as a reference?
No. The limb was the reference. TAL was not the reference. It was quite, I mean, the bony anatomy landmarks are quite different in a polio limb. So the routine landmarks cannot be followed. So you have to use your limb, which is in internal rotation, as a landmark to keep the version for the femoral stem, and same for the acetabulum.
What size cup was used, sir?
I don't remember, but then that was a quite big size cup. I don't have, I have it, but it is not here on the table.
Excellent, excellent.
Okay.
Actually, Alok,
sir,
this is actually a wonderful surgery. Actually, it is a daredevil surgery. We can see because of planning as well as selection of the implant and to do a surgery on a patient of a polio limb. She was not walking. And after even a surgery, you can just can't guarantee that what will happen, going to happen, because we don't have experience of such type of cases. A wonderful case. And so thank you very much. And next case, you can go ahead.
Thank you, sir. Thank you, sir.
Yeah, congratulations, Alok. That's a wonderful case. May I now ask Dr. Neha Godghate to start sharing her screen, and who else to introduce her? Ninad.
Thank you, sir. Dr. Neha is arthroscopy surgeon and director at Grace Orthocare Hospital, Nagpur. She did her MBBS from KEM, MS from Pune and DNB, and she did her MCH from UK, where she was awarded the prestigious Ian Kelly Award. I request Dr. Neha to please start her presentation.
Thank you. Am I audible and is my screen visible?
Yes.
Yes.
First of all, I would like to thank Dr. Gadegone sir, President MOA, Dr. Dhopavkar sir, President BOS, Dr. Pahukar sir, Dr. Kimmatkar sir, for giving me this opportunity, and Dr. Neeraj sir for giving the good introduction. So, I am Dr. Neha Godghate, consultant at Grace Orthocare Hospital, Nagpur. The topic for my today's presentation is bony Bankar's lesion. So, shoulder joint is inherently unstable joint with a wide range of motion. So, today through my presentation, I'll try to improve the understanding of instability and its management. So, thinking about the management starts as the patient enters your office. So, when a young boy comes with the complaints of shoulder instability, the first picture which comes to your mind is Bankar's lesion. Vis-a-vis a 70-year-old lady with shoulder instability, it has to be due to massive rotator cuff tear, unless and otherwise proved. Then occupation helps in deciding the physiotherapy protocol, because in sports person we need to do aggressive physiotherapy. Hand dominance will decide about the disability of the patient. We need to know whether the first dislocation was traumatic or traumatic. Like in this person, the dislocation was traumatic, so we need to know that the capsule was patulous. Number of dislocations will tell you about the bone loss. The history of previous surgery will give you the opportunity to figure out the pre-op planning. So once we are through the thorough examination, basic investigation is X-ray. It speaks 1,000 words. Like this one is obvious anteroinferior dislocation. This one, though looks it innocent, there is a widening of joint space. So this should immediately ring a bell in your mind that this might be a posterior dislocation of the shoulder, which is often missed by many. So a bilateral view will confirm the diagnosis. Another X-ray, if looked keenly, there is a small bony chip in the inferior aspect of the glenoid. So that might be a chip fracture of the glenoid. A striker notch view will help us to measure the Hill-Sachs lesion. So pathology of instability is divided into soft tissue and bony lesions. Various soft tissue lesions are Bankart, slab, Alpsa lesions. So when the labrum is detached from the glenoid after dislocation, it is termed as Bankart's. Clock face orientation is used to understand and communicate better. The other part of spectrum is Alpsa lesion, which is in this, the labrum is detached, moved medially, rotated internally, and adhered to the glenoid neck. And there is a periosteal sleeve which is avulsed. Hagel lesion is when the capsule is avulsed from the neck of the humerus. The hammock is broken and head subluxates inferiorly. So arthroscopically, the Hagel lesion will look like this. So now coming to bony loss, it might be a fragment type or attritional type. So if there is a bony fragment of glenoid, MRI or sometimes CT are needed to quantitate the fragment size. So in recurrent dislocations, there is attritional bone loss of the glenoid and it becomes inverted pear-shaped. So bony Bankart's lesion is a fracture of glenoid and detachment of labrum. So Bijlani proposed a simple classification. Type 1 is bony avulsion, type 2 is bone fragment which is adhered to medial neck of the glenoid, and type 3 is attritional bone loss. So there have been papers by Itoi, Burkhardt, Yamamoto. They are suggesting that involvement of more than 25% of glenoid area will lead to recurrent instability. So coming to my case, he is a 47-year-old gentleman presented to me with the history of fall from two-wheeler with severe pain in right shoulder. His X-ray, I would like to ask all the seniors. The prima facie it looked innocent. So I would like seniors to comment on the X-ray. So Dhopavkar, so would you like to comment on the X-ray?
Yeah. I think again I have the same problem. It is looking very magnified. I will just try to magnify the. No, but I don't think there is. This is when he presented to you, no? And
Yes,
was there any episode of dislocation before?
He said that
when he fell down?
He fell on the shoulder and he had severe pain. It was active
Okay.
dislocation.
So
I could
from
not
whatever
examine.
I can see on this X-ray, I don't make out anything that is grossly abnormal.
So, Kimmatkar, sir, would you like to comment on it?
There is some sclerosis at supraspinatus insertion site, and there is also some sclerosis or parallel area on the acromion. That could be one pathological sign I could see in this X-ray.
Right. So if we look very, I don't know if it is clear here, but if we look very carefully, so there was a small chip of bone which was lying in the axillary pouch. So this was a small chip of bone. And if we see again very carefully, the glenoid, the upper half of the glenoid is sclerotic. You can see the nice and thick line of the glenoid. However, the lower portion, lower half of the glenoid is hazy. So the MRI was done to confirm the diagnosis. So this is the coronal image which confirms the osteochondral fragment which is lying in the axillary pouch. And axial image would show a bony Bankers lesion like this. So this was a bony Bankers lesion with the osteochondral fragment which was lying in the axillary pouch. So after examination under general anesthesia, the patient was positioned in lateral decubitus with affected shoulder in 30 degree of abduction and 15 degree of flexion with arm suspended in 4 kg of traction. A standard posterior portal was created and diagnostic round of glenohumeral joint was done. So arthroscopic findings showed that this was a osteochondral fragment which was lying in the axillary pouch and which was attached to the glenoid with a small chondral tag. So weaving through the posterior portal, working through the anteroinferior portal, bony Bankers lesion was released by liberator and also mobilization of capsulolabral complex was done. After mobilization, preparation of glenoid bone or a fracture crater is done with the help of shaver by removing the scar tissues. And the rasp was used to enhance the bone healing. So this was the fracture crater which was shaved off. The scar tissue was shaved off. So then the reduction was checked and it was confirmed to be a tensionless reduction. And after that, a suture anchor was inserted at the base of the crater. A 45-degree suture lasso is passed. So this is a suture lasso which has passed through the capsulolabral complex. And another thing, there was a small piece of bone which was embedded in that capsulolabral complex. So that was also, the bite was also taken from that bone. So after that, the reduction was again confirmed and with the help of grasper, the reduction was held in the position. And then the sutures were tied over the capsulolabral complex as well as the bony fracture site, the fractured fragment. So this was his final follow-up. The patient has got good full range of motion and the apprehension test is negative. The patient is able to do all his daily activities without any pain and without any complaints of instability. So coming to discussion, Nicola in his technical note mentioned that initial diagnosis and evaluation may be difficult in acute episode as conventional radiographs have low sensitivity, but a keen eye would pick up subtle signs and MRI and CT would confirm the diagnosis. Bony Bankers lesion is basically a fracture of glenoid with Bankers lesion, and if left untreated, this may lead to malunion or non-union, and eventually it will lead to resorption of bone, and there will be, after resorption of bone, there will be a huge glenoid defect, which may lead to recurrence of dislocations. So the recurrence of dislocation is found to be 23 to 50% in conservatively managed or untreated patients, but the recurrence rate decreased tenfold, like 3 to 4.8% in surgically managed patients. So Sugaya et al. In his article in 2006 have nicely demonstrated a surgical technique and suggested that it needs only 1 or 2 suture anchors to fix this kind of fracture. So points to ponder are there is highest incidence in males in 16 to 20 years. The fixation in glenoid bone loss less than 20% is advisable. IGHL is a static stabilizer in 90 degree of ABER, and early arthroscopic repair is a better option. So this is my case. I would like to thank MOA and VOS for giving me this platform to present my case today. Thank you very much.
Yeah, I think it's a wonderful case. The suspicion on that initial X-ray only could you further clinch your diagnosis, and then the management which you have shown along with all the literature support is certainly fantastic. Congratulations for this good case. A few questions is like you are lucky to have such a big fragment here. So does this size of this fragment, Bankart, that fragment, does it matter? Will it change the plan in management?
Yes, sir. Thank you for the question. Basically, the size of the fragment matters, whether it is less than 25% of the glenoid or it is more than 25% of the total glenoid width. So if it is less than 25%, we generally go for direct fixation like this, which I had done. If it is more than 25%, then we would consider Lataje for this. If it is acute case, if it is fixable, then it should be fixed. Otherwise, Lataje would be an option.
Okay, yeah, that's. And the another question is like usually sometimes this patient come very late. Sometimes if they present 4 weeks or down the line 2 months. So do you still prefer arthroscopic or you prefer the open or the other kind of treatments then?
So my cutoff line for doing arthroscopic fixation or fixation of the bony bankers would be 3 months, because there are papers which are stating that after 3 months, if the bony bankers is fixed either with open or arthroscopic, the results are worse. Because over the period of time, if the patient has instability, the tissue quality decreases, there is a bone resorption of that bankers fragment. So generally, after 3 months, if it is sutured back or fixed back, it does not give good results. So 3 months is the cutoff line for me.
Yeah, I have one question. Is there any role of fixing a big bony chunk with some kind of a Herbert screw or a 4 mm CC screw? If it is big, and if you are doing, because I have an experience of about 2 patients where there was a very significantly big anterior fragment and I don't do any scoopy. So see, defining that fragment and identifying it and fixing it with Herbert screw, does the literature mention of doing an open fixation with a Herbert screw or a 4 mm CC screw?
Yes, sir, definitely. The literature does mention if it is more than 25% or if it is a big chunk which is fixable with a screw, because most of the times these are very small bony chips which are not amenable to fixation by screw. But if it is amenable to fixation by screw, and if the surgeon is happy doing open procedure, then definitely it can be fixed. But arthroscopically, I don't think we will be able to fix with the help of screws.
Yeah. It is something like an anti-column injury in a hip, acetabulum. If it is a bony fragment that has come out, and
certainly, sir, Dhopavkar sir, nowadays certainly it is like if you are opening and trying to fix this, better to use the suture anchor fixations.
Yeah.
And sometimes the bifocal pins, these are also available. These are more better recommended for sure.
Even if it's a large fragment, that can be fixed with a double row of suture anchors. The one suture anchor row will be above the fracture and one will be over the glenoid neck. So these two sutures will be tied so that the fragment is completely seated. So even arthroscopically, we can fix the big fragments. But if you want to use a hardware, then definitely open is also an option.
So yeah, thank you, Neha, for such a wonderful case. Now we will move ahead for the fourth case for this today's episode. This is another I think a pediatric trauma kind of case. Then I will ask the next presenter, Dr. Sanjay Sonawne, to start sharing screen. And Ninad will give a brief introduction.
Thank you, Dr. Neha. Dr. Sanjay Sonawne, sir, he is a leading orthopedic surgeon from Akola. He runs his own trauma center since almost 8 years now. He has done his MBBS and MS from GMC Nagpur and has served as a lecturer there. And he has done his fellowship in spine and joint replacement from Buckinghamshire, UK. And I would like to request Sanjay sir to please start his presentation.
Sir, you are muted. Sanjay sir?
Unmute karo.
Am I audible, Manoj?
Yeah.
Good evening, friends. I'm grateful to Dr. Gadegone sir, President, Maharashtra Orthopaedic Society, Dr. Dhopavkar sir, who is the President of Vidarbha Orthopaedic Society, Dr. Kimmatkar sir, young and dynamic Dr. Ninad, and my versatile friend Manoj for this excellent opportunity. Today I'll be speaking after very interesting presentations by Girish, by Neha, and by Alok. This is something I think would be of great help in our day-to-day practice. And this is all about isolated radial head dislocation, which is a rare and a commonly missed injury. Manoj, play nahi ho raha hai.
I think you stop. I will stop sharing. You can do it again, sir.
Shall I share it now?
Share it now. Yeah.
Yeah.
Okay. Yeah.
So a 6-year-old male child, he presented to us with an alleged history of fall on outstretched hand while playing. He was treated at periphery with crepe bandage and elbow pouch. He presented to us 8 weeks after the injury with pain and restricted elbow and forearm movements. So these are his X-rays at presentation. 2 months post-injury. Any comment, Manoj?
I hardly see any pediatric elbows nowadays. Still, I think you have already made the lateral view very well. Anybody else want to comment?
Draw the lines.
Yeah.
So, no doubt, this is radial head dislocation, AP and lateral view of right elbow. On examination, skin condition was normal. There was fullness for the anterolateral aspect of elbow. There was fixed flexion deformity of 15 degrees. Further flexion was possible up to 90 degrees. And after 90 degrees, flexion was restricted. Forearm, it was in mid-prone position. Supination was restricted. And any attempt to supinate was painful. This is in contrast to literature where they say the pronation is painful, but in this child, supination was painful. And there was no evidence of posterior interosseous nerve palsy.
So any associated you wanted injuries you wanted to see apart from this isolated radial dislocation in this case?
Yes. So we'll go to that. In next slide, Manoj, I'll be going to that. Yeah.
This was how many weeks post
Sir,
injury?
this is 8 weeks post-operative, post-injury, 8 weeks post-injury. Yeah. This is restricted elbow flexion, what he was having.
Yeah. I think it is a Montegia variant. Many a times there is a small bend fracture of the ulna, which is called Hume fracture, which goes unnoticed, and associated dislocation of radial head. And what you see at the end of 8 weeks, the fracture of the ulna might have got healed, and you see it as an isolated radial head dislocation.
So very rightly pointed out, sir. So what was that? So that was going in mind. Am I dealing with congenital radial head dislocation? No, because patient was absolutely asymptomatic till he sustained this injury. Yeah. And congenital radial head dislocation, it is bilateral. We have taken X-ray of the contralateral elbow and forearm, this X-ray, which was normal. So as you rightly said, am I dealing with Montegia's type 1 variant? But then we draw 2 lines, one line which we call as a Mubarak line, and it was not showing any ulnar bow sign. Okay. And there was no palpable callus along the subcutaneous border. This ulnar bow sign, if it is negative, that means there is no plastic deformation. And if there is bony injury, there is no palpable callus along subcutaneous border of ulna, which we commonly see in trauma cases at 2 months. And there was no tenderness over distal radioulnar joint. So again, we were in doubt whether this is Montegia's type 1 variant, as you said. And then when we searched for the literature, we came to the conclusion that probably I'm dealing with something that they call as isolated radial head dislocation. Okay. And which is a very rare and commonly missed injury. And in literature till 2005, they had mentioned only 81 cases. And if we miss this can result in limited elbow and forearm function, cubitus valgus and late nerve palsies, and chronic pain at the radiocapitular articulation. So my concerns were, can we neglect this? What is the role of close reduction? If surgical treatment is planned, when to operate, by which approach, whether it is to be done by single or double incision, what is the role of annular ligament reconstruction, what is the role of ulnar osteotomy, where to do ulnar osteotomy, how much angulation is to be given and how to fix it, and only this angulation is to be given, or should we combine it with distraction? So these were the questions. So can we neglect this? No, certainly no, because of the long-term complications. What is the role of close reduction? We can do this, we can try this only in fresh cases, maybe up to 1 to 2 weeks, trial of close reduction, confirmation under CR, and immobilization in hyperflex position. But after 8 weeks, no, there is surgery is certainly indicated. So when to operate? As early as possible, because adaptive changes make complete disorganization of the biomechanics of elbow function and forearm functions. Always close reduction, and whether to be done by single or double incision, it all again depends on surgeon. As I said, close reduction only for fresh dislocations. Open reduction of radial head, yes, always, followed by proximal ulnar distraction and or angulation osteotomy. It should be angulation and distraction osteotomy. To be added or may not be added depending on the stability of radiocapitular articulation with annular ligament reconstruction by Bell-Towse, modified Bell-Towse, or combination of 2 or 3 procedures. I'll skip a few of the literature-based slides about oligoclonal osteotomy and annular ligament reconstruction, so that we can discuss more about this case per se. So we took the patient on an operating table with in supine position with shoulder at 90 degrees abduction, elbow at 90 degrees flexion, forearm in mid-prone position or in full supination. In this case, I was able to supinate it as patient was under anesthesia. And the surgical steps were, we preferred, which we have chosen Kaplan's approach. In the literature, they have mentioned about either Kocher's approach or Boyd's approach. But here we have chosen Kaplan's as we are more anterior, and we had planned 2 incision surgery rather than a single incision surgery. So we took an interval between extensor digitorum communis and extensor carpi radialis brevis. We elevated the extensor carpi radialis longus and brachioradialis from the lateral edge of the distal humerus. Radial head was anterior to the capsule because of the buttonholing effect, and we were not able to see that. The capsule and annular ligament, they were incised to expose the radial head. The articular surfaces of radial head and capitulum were not damaged, and there was no osteochondral fragment. Capsular adhesions from radial head and from the ulnar notch, they were clean. Radial head was reduced by direct pressure. This reduction was stable during flexion and extension, as I will show in the video, and it was dislocating during pronation. This is the approach. We can clearly see, we can comfortably go anterior to the extensor digitorum communis. This is the subperiosteal elevation. And this was the capsule along with annular ligament, which we cut. We cleaned the fibrous tissue. We need to confirm that radial head is concave and it is not dome shaped. They recommend, in the literature, they recommend to go for pre-operative CT scan to assess the shape of the radial head, because the surgery is contraindicated if the radial head is dome shaped. But on X-rays, we were sure that it is not dome shaped and patient was not very affording, so we skipped CT. So flexion extension was all right, but with pronation, the radial head used to get dislocated. Then we planned ulnar osteotomy by a separate incision along the subcutaneous border of ulna. We exposed the ulna, introduced 2 spikes. The osteotomy level, it was 5 to 6 centimeters. As per the literature, it is 5 to 6 centimeters from the tip of olecranon, they say. It was in the same range. We did osteotomy with the help of fine saw, and it was near complete osteotomy, not 100%, but to keep the volar cortex bit intact, so that I can gradually open up the osteotomy dorsally. This dorsal open osteotomy also lengthened the bone to some extent. And this is how it was. The recommended degree of angulation is 10 to 30 degrees. In this case, just with 10 to 12 degrees of angulation, our head was relatively stable. And this osteotomy, because the volar cortex was not completely broken, it was relatively intact. We can hold this osteotomy site temporarily with the help of a plate and K-wire. Now you can see there is, even with forearm rotation, head is in place. It is not dislocating. So this much of dorsal wedge opening was sufficient for me. Then we pre-bent a plate, 3.5 millimeter plate was pre-bent by 10 to 15 degrees. It's a 5-hole plate we used with 2 screws proximal to the osteotomy site and 2 screws distal to osteotomy site. And you can see from this picture that the osteotomy site is open. Throughout the procedure, you should be very sure that the osteotomy is open. In this case, because radial head was comfortably, we were able to reduce the radial head comfortably. So there was no need of distraction. If we can't reduce the radial head with capitulum, we can think of distraction up to 1 centimeter. We have not added any bone graft. After plate fixation, and this is the Shyam picture. After plate fixation, this was the assessment of stability of radial head. Complete flexion extension. And complete pronation supination. This is immediate post-operative X-ray. You can see the radiocapitular line. This is 1 month post-operative. And this is at 7 months. Surgical scars were healthy. There was full elbow flexion and extension and full forearm rotations. Patient had returned to almost all normal activities. And at 8 months, we removed the implant. This is after implant removal. This is the range of motion, flexion extension. This is at 1 year, complete extension, complete flexion, complete supination, and complete pronation. So to summarize, all elbow injuries and radiographs must be reviewed at an early stage, and radial head dislocation, it may be overlooked, especially if there is no obvious ulnar fracture or plastic deformation of ulna. Proper AP and lateral, again I'm saying proper AP and lateral, because if they are not taken properly, we may miss that. Of elbow and forearm of the injured and contralateral side, they are must. It's a good practice to actually draw the lines, the radiocapitular line and Mubarak line over the X-ray films. Early reduction can prevent the long-term sequelae and complications like restricted elbow and forearm movements, cubitus valgus, and degenerative changes of radiocapitular articulation. In literature, there is no single recommended treatment, though a clear treatment algorithm is suggested. Several techniques can be used alone or in combination to achieve relocation of the chronically dislocated radial head depending on the intraoperative finding and stability. Both the integrity of the radiocapitular joint and correction of the ulnar deformity are essential for successful outcome. In this case, though there was no deformity. Open reduction of radial head, we did it by Kaplan's approach, along with angulation and or distraction osteotomy with or without annular ligament reconstruction is the most commonly performed and acceptable procedure. Thank you.
I think Dr. Sonawne said it's a wonderful case, and the different explanations, the various videos, your actual presentations, imaging, they were all excellent. We could able to understand each and every step and how did you do it. So fantastic, and congratulations for a very great case. So any comments from Dr. Dhopavkar or Kimmatkar?
Sanjay, I have one question.
Yeah.
Basically, you opened the radial head for reducing it by Kaplan's approach.
Yes, sir.
Probably because it was an isolated radial head dislocation.
Yes, sir.
If it was a Monteggia variant with a malunited proximal ulnar fracture,
yes,
would the sequence of your surgery would have been an osteotomy, lengthening osteotomy of the ulna first, and
sir,
then if required, do an open reduction of the radial head?
Sir, treatment algorithm is very well defined and standardized. It is always open reduction to start with the open reduction of the radial head.
Okay.
We can reduce it by open reduction by capsular incising the capsular annular ligament. We can reposition the radial head in place, and it is stable during flexion extension. It's good.
No need for ulnar osteotomy.
No, sir. Now the question is, shall we add annular ligament reconstruction or ulnar osteotomy is the matter of debate. Right. Rate of failure and rate of redislocation after annular ligament reconstruction by any method, it's very high.
Yes.
Success rate of ulnar angulation osteotomy, it's very high.
Right.
If you do not combine it with ulnar osteotomy, then it is clearly evident from all the literature that it has a very high chance of failure.
Right.
So the second thing would be ulnar osteotomy. Whether to just angulate it or distract it, it depends on the quality of reduction. If your head is in place, but it dislocates while pronating it, you may get away just with angulation. But if you are not able to reduce the head per se with the capitulum, you may need to distract it and additionally angulate. Angulation per se will give some lengthening, but distraction would give you sufficient lengthening. And there is what they call as a stabilizing effect of the interosseous membrane, which will help this radial head to be in place. Contact with capitulum. So no doubt about this. Now after ulnar osteotomy and fixation, angulation or distraction, whatever, and after fixation with a plate, and still you find that radial head is subluxating a bit, you may add annular ligament. Annular ligament reconstruction is still in practice, very commonly practiced, but its place would be the third in the row, if you say.
My question was, if there was an ulnar shortening,
yes,
would the sequence be a lengthening osteotomy followed by radial head reduction if required, open? You started with radial head open reduction and then added ulnar osteotomy.
Sir, if you see in this case, like there is clear evidence of buttonholing through the So even if you, what was the obstacle in reduction? Why we were not able to let it be like, if you are talking of stability, okay, it was not stable, but we were not even able to reduce it by close reduction. This means there was something, some interposition in the capitulum. This open reduction is always must. They call as open reduction of both radial head as well as osteotomy. Now, whether to do a single incision or double, it is up to you. If we go by Kocher's, there is good chance of injury to the lateral ulnar collateral ligament. If we go by Boyd's, it is too posterior for me to reach the radial head. And then if you see in this case, the overlap between the two incision, it was hardly of 1 or 2 centimeters. So I was not very much bothered about. So my radial head reduction was absolutely fine as the way we approach radial head. And my ulnar osteotomy, I was very comfortable because I was doing it by a separate incision. But treatment algorithm is same, sir, irrespective of whether I'm dealing with isolated case or with a neglected Montegia. Neglected Montegia, I do not know.
Point well taken, Dr. Sanjay. So thank you very much for this wonderful case presentation.
One point I have missed, sir, in annular ligament reconstruction, they usually add a K-wire from the capitulum to the radial head, and you know it has its own complication in the form of breakage, arthritis, and elbow stiffness and heterotrophic ossification. So annular ligament reconstruction per se has many complications, including osteonecrosis of radial head. So probably, sir, only 2 procedures, radial head reduction and osteotomy, would suffice in most of the cases, and it is properly supported by the literature available.
I think, thank you, Dr. Sanjay. Now we'll move ahead with the next case. The next episode is in the hand, and we have Dr. Samrat Taori as the next presenter. They will be presenting a case of tendon reconstruction in the case of rheumatoid wrist. Ninad, a brief intro, please.
Yes, sir. Dr. Samrat Taori is a specialist in hand, wrist, and peripheral nerve injuries. He did his post-graduation from Pune and fellowship from CMC Vellore. He's a very upcoming, dynamic, and a passionate hand surgeon. And I request Dr. Samrat to please begin his presentation. Dr. Samrat, I think you'll have to unmute.
Very good evening to everyone. Am I audible now?
Yeah.
Yeah.
Samrat, we are slightly running late, so we'll like to have it brief. Yeah.
Very brief, sir.
Yeah.
So I thank everyone, seniors and Maharashtra Orthopaedic Association for this opportunity. And this is co-authored with Dr. Hardole. So this patient was a young female who came, she's a known case of rheumatoid arthritis, and she came to us with loss of extension of the ring finger. She had stopped treatment. During. So as we can see, there was swelling in the wrist region as well as along the tendon. So synovitis and tenosynovitis was there. There was ring finger drop, suggestive of EDC rupture, and there was a dorsal ulnar prominence, so suggestive of a distal radio ulnar joint instability. The differential diagnosis for tendon loss of extensor, one is the volar subluxation of the tendon and dislocation of the metacarpopharyngeal joint. It can also occur if there is a severe affection of the flexor tendon with contracture, and if there is a posterior of palsy because of some edema and nodule formation in the supinator region in the posterior interosseous nerve compartment region. So nothing of that sort was there. This was a straightforward diagnosis. Radiocarpal arthritis was there. There was intercarpal arthritis, and there was distal radioulnar joint instability. So our diagnosis was rheumatoid arthritis with extensor tenosynovitis, with extensor tendon rupture, and a distal radioulnar joint instability. The typical Vaughan-Jackson syndrome. The extensor digiti minimi was not injured in this case, but that's a variant in that. So this is a typical line diagram, normal wrist, and what we are concerned with are the EDC here and the distal radioulnar joint here. And we see radiocarpal arthritis, we see radiocarpal arthritis, we see radioulnar arthritis, and there is osteolysis and osteopenia, as well as there is prominence of the ulnar head. Just a second. Yeah, so swelling, ring finger drop, dorsal ulnar prominence. We know Vaughan-Jackson syndrome. This is the normal relation. The normal relationship is disturbed because of the injury to the scapulohumeral ligament, injury to the scaphotriquetral ligament, where the whole carpus tries to go volar, and then that causes the radius also to be a bit volar, and the ulnar prominence with adhesion causes this sort of rupture. So we decided to operate. Our guiding principles were synovectomy to decrease the inflammatory load, repair or reconstruct whatever possible to stabilize what is impending instability, and to salvage whatever we cannot stabilize or repair. So as we opened it, we found that the EDC of the ring finger and little finger were ruptured. The EDM, extensor digiti minimi, was tenting on the ulnar head, which was very prominent. Extensor carpi ulnaris was subluxated, so it will start acting like a flexor and cause further damage. So, and there was loss of the ulnar head cartilage and loss of and there was prominence of that. That's the cut end of the EDC, and so this is the ulnar head, completely denuded, no cartilage, and it was we did not have to do much soft tissue release to get this picture. So we decided to do ulnar head excision. and this is about 2 centimeters of the ulnar head was removed. This specimen is with me since last 6 months, and believe me, I've done nothing, no change in this. This was in formalin. It is very sharp edges here we can see, and that was a very much thing causing the acquisition rupture. Once that was done, we did the ADC ring finger reconstructed by doing a pulver weave, side weave with the middle finger. So that is the pulver weave with the middle finger that was done with appropriate tension. And because we had removed the distal part of the ulna, we wanted to stabilize it. So we used the extensor carpi ulnaris stenodesis for ulnar stabilization method, where we took a part of the extensor carpi ulnaris. We took a part of extensor carpi ulnaris and used it to tenodise the distal part of the remaining ulna. At the same time, the ECO was also stabilized by using a retinacular flap, as seen here. So this is the book picture of the procedure done for the stabilization of the ulna. This is a 4-month post-surgery X-ray. What we see is that there is no change in the whatever relationship of the carpus and the radius was, but the ulna seems stabilized. And the patient is quite comfortable, her extension is restored, flexion is completely doing. There is classification of the rheumatoid arthritis risk. Our concern is that there is ankylosing type where it is a spontaneous fusion, that is it. Then there is the osteoarthritic type where there will be osteoporosis, sclerosis, but ultimately they also stabilize. We have to look for those patients with degenerative type of disintegrative type of rheumatoid arthritis risk, where there is more of ligamentous instability, there is marked destruction, and there can be a complete loss of anatomy and such picture. So in spite of our literature, the last literature, that even if we have got biologics and very good drugs, still there will be some short subset of people who we have to look for, which may require synovectomy or further corrective surgeries. So to end with, the guiding principles for the treatment are synovectomy, decrease the inflammatory load, repair or reconstruct, stabilize which is impending, unstable like extensor carpi ulnaris in this case, and salvage. That is, we remove the ulnar head and we stabilize the part. And lastly, we don't treat this X-ray. We know we treat how. Not bothered about the X-ray. Generally, in rheumatoid arthritis, the patient adapt very well with whatever disabilities they have, deformities they have, and they adapt and make the disability minimum. Thank you very much. Thank you.
I think that was Samrat, a very wonderful, rare thing which we have learned. Can you go back to the slides? You can finish the indications, I suppose. Yeah. I think those were also very important. You missed 2 slides. You wanted to present those? These, I think.
I think, sir, sorry. These indications are a bit bookish, sir. My most important slide is this, sir. There are, in spite of everything, patient may come with some lingering type of synovitis, and there will be a slow acquisition and rupture of them. So we have to look out for these patients. Otherwise, these are the indications where there is a painful synovitis which is lasting for 6 months, or there is a tendon rupture, and if there is a limited forearm rotation, actually that means that there is some problem with the distal radial ulnar joint or a proximal radial ulnar joint, or patient is not able to do a chuck pinch, that is this one. So again, it means that the smaller muscles are getting compromised, unable to do power grip, which indicates gross synovitis, because of which the patient is not able to completely flex. Entrapment neuropathy, as we know, and appearance of the hand is something, yes, that is also has to be considered.
Yeah. I think Samrat, that was a very great presentation, and I think how common are these injuries, right? Apart from usually rheumatoid hand, we see the finger deformities more often, and sometimes we neglect the wrist. Apart from the arthritis, these tendon problems happening at those levels. So, how common are these problems?
Sir, I very humbly feel that the synovitis is very common. Isolated rupture of tendons is common, but patients don't come to us. We need to work on that. And as you said, ulnar deviation of the fingers because of the volar subluxation of the extensor tendon, that is common. And the type 1 and type 2 of the arthritis, where there is a slow growing arthritis, radiocarpal arthritis and intercarpal arthritis, we see these cases sometime here and there. So, and all many of them are salvageable, means we can do a limited radio scaffold unit fusion. That decreases a lot of pain and has got some ROM still there. So I think there's a, we need to, there are patients who require surgery.
Yeah, I think one more question I'll let us, like the rheumatoid hands we see very commonly. So there could be multiple deformities in the fingers, then in the wrist. So how do you decide which deformity to operate, which to conserve? Any guidelines briefly you could make out for all of us, like the Butner deformity, if it is in the index finger, wrist there is some luxation, little finger having mallet finger. How do you protocolize to operate which amongst these?
Sir, those deformities which can deteriorate and cause other problems, that is like the wrist, this caput ulni, which I have presented, where the ulna is prominent. This is something which has to be acted fast before the patient presents to us with extensor tendon rupture. Many cases of buttoner deformity or a swan neck deformity initially can be treated with splints, and those patients may require, they may be benefited by soft tissues surgery, or they may require fusion also. So that is something which patient will decide.
Okay, I think the rheumatoid hands are certainly very complex problems, and you have certainly made a very good case and certainly good outcomes, and we could able to gather good information. Any more questions we should like to ask to Dr. Samrat? Nina?
Samrat, do you face any wound healing problems?
Yes, sir. I have not faced in this case, but we have to be very cautious about it. One is patient may be on a chronic steroid use. The soft tissue is fragile. The skin may be also fragile. One thing I learned when I was under fellowship through Vidarbha Orthopaedic Society with Dr. Mukund Thatte was that we stopped methotrexate about 2 weeks before surgery, and we don't give for another 2 weeks. So methotrexate is to be avoided after surgery because it may hamper the wound healing. That's the mechanism of action of methotrexate that way. That's it, sir.
Thank you.
Yeah. Okay, Samrat. Thank you very much for this wonderful case. And now we move ahead for the final case for this today's episode. And it is the last dish, the dessert, I think, from the arthroscopy of the knee case. May I invite Dr. Dhananjay Deshmukh to start sharing his screen. And he will be presenting a case of, I think, a hidden lesion of the posterior horn of medial meniscus. Ninath, please introduce.
Thank you, sir. Dr. Dhananjay, he is a arthroscopy and joint replacement surgeon from Amravati and director at Sunshine Super Specialty Hospital. He has done his post-graduation from JJ, Mumbai. He has done MCH from Dundee University and fellowship in arthroscopy and joint replacement from Germany. I kindly request Dr. Dhananjay to please start his presentation.
Thank you, everyone. I'm just arranging my slides. Am I audible and visible?
Yes.
As we are already getting it, I will directly come to my topic.
Yeah, I think reach the end of the slideshow. We can start.
Okay, today I'm going to talk regarding the hidden lesion in the posterior horn of medial meniscus. that is a ramp lesion. Roughly, we can call this as longitudinal and vertical tear, which are peripherally affecting the posterior horn of middle meniscus in a mediolateral direction of less than 20 millimeter, which are causing disruption of meniscocapsular and meniscotibial ligament. Why I'm calling less than 20 millimeter? Because the length of the posterior capsule is approximately up to 20 millimeter. We all know the basic anatomy of the posterior horn of middle meniscus, where posterior capsule, the meniscocapsular and meniscotibial ligament are attached to the posterior horn of middle meniscus. The incidence of ramp varies from 15 to 45% in patients who are undergoing ACL reconstruction. The classification of the ramp lesion is basically into 5 types. Type 1 is meniscocapsular ligament tear. Type 2 is partial superior tear. Type 3 is partial inferior tear. And type 4 is complete tear. And type 5 are double tear. And again, these tears are further classified considering their proximity to the meniscal blood supply, whether they are in red zone, red-white zone, or white-white zone. Type 1 are basically capsular meniscal junction lesions, peripherally located in synovial sheath. And during arthroscopy, when we do probing of such lesions, the mobility while probing is very much low. Type 2 lesions are partial superior lesions, stable lesions. They can be diagnosed by transnose approach. And again, the mobility while probing is low. Type 3 are partial inferior or hidden lesions, difficult visualization through transnose approach. So high suspicion should raise while we are doing probing when there is high mobility. Type 4 are complete tear in red zone, mobility and probing is very high. And type 5 are double tear. Basically, all these ramp lesions are underreported. And type 3, type 4 and type 5 are hidden lesions. So how to suspect a ramp lesion in a patient who is having ACL injury? The candidates who are having high instability episodes, having high grade of anterior drawer test, a pivot shift test, which is of high grade level. And the diagnostic tools which we use for diagnosing such lesions are, we should look on MRI for the tear of the ramp lesions. We should look for the secondary signs on MRI. But are MRI 100% reliable? Because according to literature, only less than 1 of the patients were diagnosed on preoperative MRI, whereas posteromedial bone bruise on tibia was found to be secondary sign of a ramp lesion in 72% of the patients. So, a systemic sequential approach is necessary to identify and diagnose these hidden lesions. So, how to treat such lesions? We can treat them from all inside method, inside out method. If we don't do repair of this ramp lesion, it has been found that there is high grade of dynamic rotatory laxicity in those patients who are having ramp lesion along with ACL injury, rather than those patients who are having only isolated ramp lesions. This is my case, a 20-year male having road traffic accident, having a grade 3 anterior drawer test, a Lachman test positive, and in MRI, we can see clear-cut a ramp lesion present here. Hello. Hello.
Hello.
Am I audible?
Yeah, very much.
Okay. As usual, it is underreported. You can see on the MRI, they have not mentioned regarding the ramp lesion. Just they had mentioned regarding the partial tear of the anterior cruciate ligament. Why I said a systemic sequential approach is necessary, because while doing routine arthroscopy, we use only anterolateral porter for visualization. But in ramp lesions, we have to make a separate posteromedial porter to see the ramp lesion. As they are hidden lesion, we have to do superficial debridement to remove the membrane. And after that superficial debridement, we are able to clearly visualize the extent of ramp lesion. Initially, we used to take a separate posteromedial approach, probe the ramp lesion, see the extent of the ramp lesion, see the mobility of the ramp lesion. If the medial joint space is too low, we can't probe these ramp lesions. So we have to do medial collateral ligament pie crusting. Here you will see that the medial compartment is opened widely after doing pie crusting. So we can do probing and we can see the extent of the ramp lesion, whether it is mobile or not mobile. This is case which I had presented where we had done the repair through all inside Fastfix 360 suture repair. We were able to manage with the 2 Fastfix sutures. The most important part is a sequential and a systemic approach, where we have to go through the intercondylar region. We have to identify the ramp lesion. We have to classify it, whether it is type 1, type 2, type 3, type 4, or type 5. Because if you don't repair the ramp lesion along with anterior cruciate ligament, they lead to rotator laxity. So the take-home message is, those ramp lesions who are unstable, who are having more than 10 millimeter of mobility, should be repaired. Either we can take a separate posteromedial approach, or we can repair through anterior approach, or we can use combination, as the prevalence of ramp lesion is 20% overall cases, and the outcome of ACL surgery improves after repair of ramp lesion. Thank you. Hello.
Hello. Yeah, Dhananjay, I think it was a good presentation, and certainly these hidden injuries, the ramp lesions, which have changed the management of ACL injuries. Neha, any questions? Yeah.
Yeah, Deshmukh's a very excellent case. I just wanted to know whether you probe every time you probe for ramp lesion, because most of the time, every ACL tear you probe for ramp lesions.
Yeah, nowadays.
Extra portal for probing the ramp lesion, and in type 3 lesions which are really hidden. So how do you know that there is a lesion?
Yeah, in early days, when you used to operate ACL patient, they used to say some discomfort is there while doing complete flexion. So in early days, we used to take a separate posteromedial portal, needling. They had mentioned that technique: needle the superficial part, remove the superficial membrane, and then probe it. Basically, these are called hidden lesions because they are hidden below that superior membrane that is formed in the ramp lesion. Now, secondly, we have to judge whether they are stable or unstable. We have to probe them. Do the pie crusting of middle meniscus, MCL, okay? Probe them. If we are able to pull them up to the middle of the femoral condyle, then we should repair them. If they are more than 10 millimeter, we have to repair them.
If you find just a tear, then you don't repair. If it is in a capsulolabral area, in a capsulolabral junction, it is a red right zone.
Mobility.
So if it is not mobile, then you just leave it.
Yeah, we have to leave them. They are the stable lesions. They are the stable lesions. Type 1, type 2, we have to leave them.
Okay.
So which configuration of anchors you wanted to use? Like the all inside, direct side to side, or any particular crisscross sometimes?
There are 3 types of anchors where you can have a straight fast fix 360 or a curved fast fix 360. Whichever you are familiar with, that you can use that.
Dr. Dhananjay? Very nice presentation. I just have one question. How do ramp lesions differ from bucket handle tears?
Basically, ramp lesions are present in the meniscocapsular and meniscotibial junctions, and bucket handle tear are in the substance of the meniscus. That is the main differentiating point. Bucket handle tear are easily visible. Either the part comes in between the condyle, but for the ramp, we have to go to the intercondylar notch approach to diagnose.
Okay, thank you.
So any more further questions from the party? Other delegates? Any Dhopavkar sir or Kimmatkar sir? Yeah.
No, nothing.
Okay. So thank you, Dhananjay. I think it was a wonderful, good presentation for this hidden lesions during your knee arthroscopy, which everybody must try to look whenever you try to go for an ACLR. So with this, I think we have finished all our 6 cases, and all the presentations were quite fantastic with good take-home messages. May I ask now Neeraj to present the vote of thanks?
Yes, sir. So today we were fortunate to use MOA platform to share the work of young orthopedic surgeons from Vidarbha. And for this, I would like to express my sincere gratitude to President of MOA, respected Dr. Gadegone sir. I wholeheartedly acknowledge the efforts of all our dignitaries of today's webinar, MOA Secretary, Dr. Karne sir, Moderator, Dr. Manoj Pahukar sir, Convenor and President of VOS, Dr. Makarand Dhopavkar sir, MOA Executive, Dr. Nitin Kimmatkar sir, in making this event successful. I am sincerely grateful to all our speakers for the wonderful presentations. They are some of the finest orthopedic surgeons, and I'm sure their work will inspire many young orthopods to venture in this exciting field with passion and energy. It is said that you can't use up creativity. The more you use, the more you have. I am short of words to express gratitude to Dr. Ashok, Shyam and Dr. Neeraj Bijlani for creating this dynamic platform for us to learn, explore, enhance, and contribute. Last but not the least, on behalf of Team VOS, I sincerely thank all our viewers for attending this webinar. Thank you so much.
Yeah. So I must thank again the Vidarbha Orthopaedic Society, especially Dr. President, Dr. Dhopavkar, Dr. Godghate for coordinating and managing the whole show and bringing out the best of the speakers from the Vidarbha. I think we certainly have one of the best session from amongst the YSF for this today episode. So again, I thank you all for your wonderful efforts and time taken and excellent presentations. Thank you again. Yeah.
Thank you.
Thank you.
Thank you. Thank you, Manoj. Thank you. Thank you, sir.
Can we stop recording, Rushi? I think recording is still going on.
Take care, Manoj, Alok.
So, yes, Sanjay.
We take a screenshot.
Yeah, I think
Smile.
we can take a photo maybe. Yeah.
I'll take a screenshot.
Okay.
So when is the next YSF?
I think we are planning with Nanded Orthopaedic Society, maybe after 2 weeks.
Okay. So in advance, how many like you plan?
And we are going on searching. The 2 at the moment are there, and Neha is also doing good job. Already 2 good webinars with the woman orthopedic team. She has coordinated very well. So we can look forward from when they are presenting certainly very good cases.
Thank
Was
you.
Okay.
excellent meeting, sir, today.
Yeah.
Thank you.
Very
I'll
nice
share the
interaction.
screenshot with you. Yeah. Thank you.
Thank you again, all.
Yeah.
Okay, sir. Okay. Bye, everyone. Yeah.
Bye.
Bye.